Welcome back to Pill Talk. Today we will discuss about a very crucial topic in pathology, that is peptic ulcer disease. Peptic ulcers are a common and sometimes painful condition that affects millions worldwide. They can occur in the stomach or the first part of the small intestine, the duodenum, and are often caused by an imbalance between the digestive fluids in the stomach and the protective mechanisms of the gastric lining. So in this lecture we will explore the causes, symptoms, and some fascinating insights into the pathology of PUD. So grab your notebooks and let's begin our journey into the understanding of peptic ulcer disease. So let's start by defining what a peptic ulcer is and how it differs from an erosion. So ulcer is defined as disruption of the mucosal integrity of the stomach and or duodenum, leading to a local defect or excavation due to active inflammation. Erosion differs from an ulcer in being partial thickness mucosal defect. So on the other hand, erosion is a superficial break in the mucosal lining that does not extend beyond the muscularis mucosa. It's a shallow lesion that affects only the surface layer of the stomach or intestinal lining. So the key difference between the two is the depth of the tissue damage. And erosion affects only the superficial layers while an ulcer penetrates deeper, causing more extensive damage. So understanding the distinction is essential as it determines both the clinical presentation and the management strategies we use for patients. Before moving further, let's outline the objectives of today's presentation. By the end of this lecture, you should be able to understand the definitions and differences between ulcers and erosions. We will discuss about the pathogenesis of peptic ulcers, morphology of peptic ulcers, and some complications. You will be able to identify the potential complications associated with peptic ulcers. With these objectives in mind, let's begin by exploring the pathogenesis of peptic ulcer disease. So by the help of this image, you will be able to understand progression. Normal mucosa will get inflamed and leads towards inflammation, and inflammation leads toward erosion, and erosion then ultimately leads toward ulceration. So to understand the development of peptic ulcer disease, it is essential to examine the delicate balance between aggressive factors that can damage the gastric and duodenal mucosa and defensive factors that protect it. Aggressive factors are usually gastric acid and pepsin, a digestive enzyme that can degrade mucosal proteins when it comes into direct contact with the mucosa. So defensive factors are there to counterbalance these aggressive factors. The body relies on several protective mechanisms, including surface mucus secretions, bicarbonate secretion into mucus, which neutralizes acids in the mucosal layer, maintaining a near neutral pH at the epithelial surface. Mucosal blood flow provides nutrients and oxygen to the mucosal cells and helps remove harmful substances. And obviously, elaboration of prostaglandins, they play a key role in maintaining a mucosal integrity by stimulating mucus and bicarbonate secretion and enhancing mucosal blood flow, epithelial regenerative capacity. So the rapid turnover and repair of damaged epithelial cells help maintain the mucosal barrier. So pathogenesis occurs when there is an imbalance between these aggressive and defensive factors. When aggressive factors overpower the body's defenses, the mucosal lining becomes damaged, leading to ulcer formation. So as you can see through this slide, you can see aggressive factors are overpowered by some causative agents, or you can say factors. Helicobacter pylori infection, NSAIDs, tobacco, alcohol, gastric hyperacidity, duodenal gastric reflux. In comparison, you can see impaired defenses are there, and impaired defenses reasons are there: ischemia, shock, delayed gastric emptying. These kind of impaired defenses and this kind of imbalance would ultimately lead towards a peptic ulcer formation. To better understand how peptic ulcers develop, let's look at this visual representation of the balance, or rather the imbalance between aggressive and defensive factors, as we already discussed. So now let's discuss the key risk factors that can increase the likelihood of developing peptic ulcer disease. These factors can either increase acid production, weaken mucosal defenses, or both, and they can lead towards the formation of ulcers. Number one will be Helicobacter pylori infection, NSAIDs, smoking, cigarette consumption, COPD, illicit drugs like cocaine, alcoholic cirrhosis, psychological stress, endocrine cell hyperplasia, ZE syndrome, also known as Zollinger Ellison syndrome, where there is excessive secretion of gastric acid due to gastrin-producing tumors, significantly increase the risk of peptic ulcers, and viral infections like cytomegalovirus and HSV herpes simplex virus. So, Helicobacter pylori is a major cause of peptic ulcer disease, and its mechanism of ulcer formation involves several key steps. Number one step will be the colonization of the gastric mucosa. Helicobacter pylori uses its flagella to penetrate the mucous layer of the stomach, where it adheres to the epithelial cells. And the second step will be the neutralization of gastric acid. In this step, the bacterium produces urease, an enzyme that converts urea into ammonia and bicarbonate. So this neutralizes the acidic environment around the bacterium, allowing it to survive in the harsh gastric environment. Number three step will be the induction of inflammation. Helicobacter pylori releases virulence factors, two types of cytotoxins, SAG-A and VAC-A, which trigger an inflammatory response by activating immune cells and releasing pro-inflammatory cytokines. Number four step will be the disruption of the mucosal barrier. So the inflammation damages the gastric epithelial cells and disrupts the protective mucus layer, making the mucosa more vulnerable to acid and pepsin. And number fifth step will be the increased gastric acid secretion. So in some cases, Helicobacter pylori infection can increase gastric acid production by altering the regulation of gastrin, a hormone that stimulates acid secretion. So this further contributes to mucosal injury. And number six step will be the epithelial cell damage and apoptosis. So the toxin produced by the Helicobacter pylori and the resulting inflammatory response cause direct damage to the epithelial cells, leading to cell death. So number seven, the last step will be the ulcer formation. With the combined effects of increased acid secretion, direct epithelial cell damage, and disruption of the mucosal barrier, the mucosa become eroded, so eventually forming an ulcer. So these steps illustrates how Helicobacter pylori creates an environment that leads toward mucosal damage and ulcer formation. So understanding these mechanisms help in targeting treatments such as using antibiotics to eradicate the infection and reduce ulcer recurrence. So the summarized form of all these steps are presented here in the form of flowchart. As you can see, only one new addition is written here. So the organism attached to mucus secreting cells of gastric mucosa by two adhesion proteins named as BAP-A and SAB-A. We should also know about Helicobacter pylori virulence factors that are named as flagella. Adhesion is caused by two proteins, SAB-A and BAP-A, urease enzyme obviously, and toxins. As we already discussed, two toxins we discussed here as cytotoxin associated gene A, SAG-A, and vacuolating cytotoxin A, VAC-A. Let's see how NSAID causes ulcer. NSAIDs such as aspirin, ibuprofen, and naproxen are commonly used to medications that can lead to peptic ulcers. NSAIDs inhibit the cyclooxygenase enzyme COX-1 and COX-2. So this reduces the production of prostaglandins, which play a critical role in maintaining the protective lining of the stomach by stimulating mucus and bicarbonate secretion. So endothelial effects will be like stasis, which leads toward ischemia, and epithelial effects will be like increase in HCl secretion, decreased mucus secretion, decreased bicarbonate secretion, decreased surface active phospholipid secretion, decreased epithelial cell proliferation. So now let's discuss about the sites of peptic ulcer. Duodenum, first portion, anterior valve, stomach, usually antrum, lesser curvature is more common as compared to greater curvature in the margin of gastroenterostomy. And these are the site basically at which surgical connection is performed between the stomach and the jejunum, often performed in gastric bypass surgery or to bypass gastric obstruction. So these ulcers are also known as marginal ulcers. So in the duodenum, stomach, or jejunum of patients with Zollinger Ellison syndrome, and another rare site for peptic ulceration is Meckel's diverticulum. Basically, it is a congenital outpouching of the small intestine that may contain ectopic gastric tissue capable of secreting acid, leading to ulceration. So next is Zollinger Ellison syndrome. It is basically a condition in which a gastrin-secreting tumor or hyperplasia of the islet cells in the pancreas causes overproduction of gastric acid, resulting in recurrent peptic ulcers. So now let's look at the two common types, duodenal ulcers and gastric ulcers. Duodenal ulcers occur in the first part of the small intestine, known as the duodenum. They are the most common type of peptic ulcer, and a duodenal ulcer often cause pain that improves with eating. Patient might experience pain that awakens them at night and is relieved by antacids or food. And the main causative agent is Helicobacter pylori. On the other hand, gastric ulcers occur in the lining of the stomach. Gastric ulcers usually cause pain that worsens with eating. This type of ulcer may cause nausea, vomiting, and weight loss. Main causative agents are Helicobacter pylori and NSAIDs. Now let's talk about the gross morphology of peptic ulcer disease. They are basically round to oval, sharply punch out defect. Mucosal margin usually level with the surrounding mucosa or only slightly elevated. Radiating mucosal folds are there. Base is smooth and clear owing to the peptic digestion of exudates. If we talk about microscopic morphology of peptic ulcer disease, 4 zones will be seen. Number 1, layer of necrotic fibrinoid debris. Number 2, zone of acute inflammatory infiltrate, also known as neutrophils. Number 3, active granulation tissues with mononuclear leukocytes. And number 4, fibrous scarring. Here are some clinical features of peptic ulcer disease. Number 1, epigastric pain, dyspepsia including belching, bloating, distension, and fatty food intolerance, heartburn, chest discomfort, hematemesis or melena resulting from gastrointestinal bleeding. So the hematemesis refers to the vomiting of blood. The blood can appear bright red or have a coffee ground appearance, which indicates it has been partially digested. And on the other hand, melena, this is the passage of black tarry stools. The black color results from the digestion of blood in the gastrointestinal tract. Here are some complications of peptic ulcer diseases. Number 1 is hemorrhage. So blood vessels damage as ulcer erodes into the muscles of GIT. Coffee ground vomitus or occult blood in tarry stools will be seen. Perforation is caused when ulcer erode through the entire wall of the GIT. So bacteria and partially digested food spill into the peritoneum, which will lead towards peritonitis. Narrowing and obstruction is caused by swelling and scarring, which will lead toward obstruction of food leaving the stomach, that will lead towards repeated vomiting. In this slide, you have to focus gastric ulcer erode left gastric vessels and splenic vessels, and duodenal ulcer erodes gastroduodenal artery. So these are the list of questions which can be formed from the topic we have covered today. So to wrap up, peptic ulcer disease is a common but potentially serious condition that requires a comprehensive understanding of its causes, symptoms, and treatment strategies. I hope this video has clarified the key aspects of peptic ulcer disease for you. Don't forget to like, share, and subscribe to Pill Talk for more updates and educational content. Thank you for watching. Stay healthy and stay informed.